Hi, and welcome to the first clinical case discussion on Medscape lectures. Now, this is an interesting case of a 22-year-old who fell asleep on a plane and didn't wake up. He was brought to the casualty in a semi-conscious state, returning from a 3-week vacation in a malarial zone, and all his other travel companions are fine and asymptomatic. We take a brief history and see that he arrived at the airport before boarding in a complete normal physical and mental status, ate his lunch on board, and decided to take a nap. But his friends couldn't wake him up while landing, and he was in a half-conscious state. So he was rushed to the nearby hospital in an ambulance. Now we see this patient in the casualty as a treating doctor. On examination, he is obtunded or lethargic, minimally arousable. Vital signs shows an oral temperature of 37, pulse at 85, BP at 110/70, a low respiratory rate at 7 breaths per minute, but oxygen saturation 98% in room air. Skin shows diffuse flushing without any lesions or bruising. Heart sounds and lung sounds are normal and clear. Head and neck examination shows pinpoint pupils, otherwise normal. Abdomen has normal bowel sounds without distension or tenderness to palpation. Rectal examination shows normal tone, heme negative stool, and no masses. Now, after the clinical examination, we do some lab work. Send a complete blood count, which shows a normal WBC, a complete metabolic panel, coagulation profile, which are normal. Some of the values are creatinine at 1.2 mg per deciliter, a blood glucose at 90, prothrombin time 12.1 seconds, partial thromboplastin at 28.5. Urine analysis is negative for bacteria and specific gravity is at 1.010. And we get to know that the HIV test of this patient was negative approximately 4 months ago from the companions. So after the lab test, we do a chest x-ray which prompts us to do an abdominal x-ray, and this is what we see. So I would recommend everyone to take a close look because this hints at the diagnosis. So what does this patient have? Is it malaria, toxoplasmosis, hepatitis, or opiate overdose? Like most of you would have rightly guessed, it is opiate overdose. We shall look into the details. Let's begin by examining this x-ray carefully. What do we see? We see some drug-filled condoms in the stomach, small intestine, colon, and rectum. Presumably one of them must have ruptured during the flight, causing the patient's drowsiness and other symptoms. Now we understood that this was some kind of drug trafficking. So let's discuss this case in detail with the theory first. Body packing refers to individuals who swallow or pack body orifices with drugs to transport them across borders, as we saw in this case. Body stuffing refers to individual who swallows drugs in an attempt to avoid prosecution by the police. What kind of drugs are transported in this manner? It can be anything from cocaine, heroin, amphetamine, marijuana, and hashish. And the quantity is often up to 1 kilogram of these drugs, which is divided into 50 to 100 packets of 8 to 10 gram each. Up to 200 packets have been discovered from some drug traffickers. The drug is first packed into a balloon or condom, followed by additional layers of latex and finally sealed with wax. This is often done with the help of machines and carefully done to avoid rupture, as rupture can expose the patient to high and fatal amount of drug at once. Now, after understanding a bit of theory about body packers, let's see what we find on a medical examination in these patients. We need to look at the vital signs mental status of the patient, pupillary size is often an indicator. For example, in this case, it was myotic, bowel sounds, and skin findings. It is recommended to do a gentle rectal and vaginal examination to see if there are any drug bags in the orifices. Look for signs of intoxication. In case of cocaine, it is anxiety, tachycardia, mydriasis, hyperthermia, seizures, vomiting, followed by respiratory depression, heart arrhythmias, or myocardial depression. While in case of heroin overdose, it is sedation, meiosis, diminished bowel sounds, followed by respiratory depression, which we saw in this case. And some patients present with gastrointestinal symptoms of obstruction, hemorrhage, or perforation. Now let's see how to investigate these patients. Plain X-rays of the abdomen and pelvis has a sensitivity of 85 to 90%, which is very good. Hashish appears, for example, denser than stool on an X-ray. Cocaine appears similar to stool, and heroin has a gaseous appearance. So it can help us differentiate which drug is present in the body to some extent. Contrast enhanced CT is more sensitive than a plain X-ray, and barium studies can also help us identify the packets as filling defects. Urinary toxicology tests are often done to see which kind of drugs are present, but these may also give some false positive tests. Now let's look at some images taken of these patients. First, the plain X-ray and the CT with contrast. Here we see plain X-rays from 3 different patients showing the drug-filled packages all along the stomach and intestine. These 2 images shows CT with contrast where the packages are very clear within the intestine. Now this is a barium swallow. You can see in the first image the descending colon does not show any abnormal foreign bodies. But in this image, after evacuation, there are barium coated packets in the descending colon. Now this is a 3D image which shows clearly these drug-filled packs. And these are the different variants of drug-filled condoms and plastic packages. Now let's see how to treat these patients. We can broadly classify them into asymptomatic cases, those with opioid poisoning, and those with cocaine poisoning. Though the treatment may vary depending on the drug they are exposed to. In asymptomatic cases, we have a conservative line of treatment while one waits for spontaneous evacuation. Opioid poisoning is treated with continuous infusion of naloxone, which is the antidote. High doses are required, and acute lung injury because of opioid poisoning is treated with oxygen or intubation as needed. Now coming to cocaine poisoning, patients are given high doses of benzodiazepines followed by ICU management, and we treat the symptoms. For example, ventricular arrhythmias are treated with lidocaine and hypertonic sodium bicarbonate. In some patients with cocaine-induced hypertension, we treat them with IV sodium nitroprusside or phenterlamine to control the hypertension. But in case of leaking cocaine packets, when patients are suspected to have leaking cocaine packets, immediate surgical removal is indicated. There is no specific antidote available for cocaine poisoning. Now, before we conclude the treatment part, we shall discuss the gastrointestinal complications these patients may present with. They may have bowel obstruction, where we give activated charcoal at a dose of 1 gram per kilogram body weight every 4 hours in repeated doses. We should be very careful with laxatives. Oil-based laxatives should not be used. No to enemas and rectal catheters because of the possibility of packet rupture. Endoscopic retrieval of packets are also very risky. And we have to do a repeat imaging until 3 packet negative stools are obtained to confirm that no packet is left behind. Now, some patients require surgical management if they have intestinal obstruction or perforation, for example. So they undergo an open surgery with enterotomy incisions, and the intestinal contents are milked towards the incision or the anus. And post-operatively, an imaging is done with CT or barium study to make sure that no packages are left behind. So before we end, let's see what happened to our patient. The patient was administered an naloxone drip and was prepared for surgery. We saw that he had an heroin intoxication. There was evidence of packet rupture inside the abdomen and the packets were successfully removed. The surgery went well and he recovered. Now that was the end of our clinical case 1. Hope you learned something new. Thanks for watching.